Acute cholecystitis is an inflammation of the gallbladder. It usually occurs when a gallstone completely obstructs the gallbladder neck or cystic duct. Biliary colic is the most common presentation, caused by a gallstone impacting in the cystic duct or the ampulla of Vater. The second most common presentation is acute cholecystitis, caused by distension of the GB with subsequent necrosis and ischemia of the mucosal wall. Repeated attacks of acute cholecystitis lead to chronic cholecystitis, in which the walls of the GB become thickened and scarred, and the GB becomes shriveled. In severe cases, symptoms can include pain in the RUQ, jaundice and high swinging fevers with rigors and chills, the presentation termed as Charcot's triad. Pathological classifications of acute cholecystitis include edematous cholecystitis, occurs after 2-4 days of obstruction. The gallbladder tissue is intact histologically, with edema in the subserosal layer. Necrotizing cholecystitis occurs after 3-5 days of obstruction and is characterized by edematous changes in the gallbladder, with areas of hemorrhage and necrosis. Necrosis does not involve the full thickness of the gallbladder wall. Suppurative cholecystitis occurs after 7-10 days of obstruction and is characterized by thickened gallbladder wall with white cell infiltration, intrawall abscesses, and necrosis. May result in perforation of the gallbladder and a pericholocystic abscess formation. Chronic cholecystitis occurs after repeated episodes of mild attacks and is characterized by mucosal atrophy and fibrosis of the gallbladder wall. Acute on chronic cholecystitis refers to an acute infection that has occurred in chronic cholecystitis. Acalculous cholecystitis is inflammation of the gallbladder which occurs in the absence of gallstones. It typically occurs in critically ill people due to a combination of risk factors. Types of stones. Bile contains cholesterol, bile pigments from broken down hemoglobin, and phospholipids. If the concentrations of these vary, different kinds of stones may be formed. Cholesterol stones. 80% of all GB stones in the UK are large, often solitary and radiolucent. Black pigment stones are small, friable, irregular, and radiolucent. Risk factors include hemolysis, EE, sickle cell anemia, hereditary spherocytosis, thalassemia, and cirrhosis. Mixed stones are faceted and are comprised of calcium salts, pigment, and cholesterol. 10% are radiopaque. Brown pigment stones, less than 5% in the UK, form as a result of stasis and infection within the biliary system, usually in the presence of Escherichia coli and Klebsiella. Gallstones account for 90–95% of cases of acute cholecystitis. Obstruction of the gallbladder neck or cystic duct by a gallstone causes bile to become trapped in the gallbladder, resulting in irritation and increased pressure in the gallbladder. If the obstruction is partial and of short duration, the person experiences biliary colic, characterized by severe pain and tenderness of the right side of the abdomen and/or back. Acute cholecystitis occurs when the obstruction is complete and prolonged, usually several hours. Trauma caused by the gallstone stimulates the release of prostaglandins, which mediates the inflammatory response. As the gallbladder becomes more distended and inflamed, blood flow and lymphatic drainage are compromised, leading to mucosal ischemia. Secondary bacterial infection of the bile may occur. Continued inflammation, ischemia, and/or infection can result in necrosis and gallbladder perforation. Acalculous cholecystitis, gallbladder inflammation without gallstones, is seen in about 5–14% of people who present with acute cholecystitis. The exact cause is poorly understood. However, functional cystic duct obstruction is often present and is associated with bile stasis or thickening. It typically occurs in critically ill people due to a combination of risk factors that result in bile stasis, such as trauma, severe systemic illness, and prolonged total parenteral nutrition use, or bile thickening, such as fever and dehydration. Other factors may be involved, such as a predisposition to bacterial colonization of static gallbladder bile. Risk factors. Risk factors for gallstones include increasing age, female gender, obesity, and a low-fiber diet. Acalculous cholecystitis typically occurs in critically ill people due to a combination of factors that result in bile stasis due to gallbladder hypomotility dysmotility, or bile thickening due to dehydration. Conditions associated with biliary stasis or thickening include sepsis, extensive trauma, burns, major surgery, prolonged fasting or starvation, prolonged total parenteral nutrition use. Other risk factors for acalculous cholecystitis include diabetes, end-stage renal disease, congestive heart failure, coronary artery disease, and peripheral vascular disease. Drug treatments, for example cyclosporin, can decrease bile acid secretion, leading to sludge formation. Ceftriaxone is secreted into bile and can precipitate with calcium, forming biliary sludge. Infection, such as Epstein-Barr virus, EBV infection. In people who are HIV positive, cholangiopathy due to infection with Microsporidia species can occur. Complications and prognosis. Without treatment, acute cholecystitis may resolve spontaneously within 7 days. However, 25–30% of people will require surgery or develop complications, such as necrosis of the gallbladder wall, gangrenous cholecystitis, perforation of the gallbladder, occurs in about 10% of people with acute cholecystitis and has a mortality rate of up to 30%. Biliary peritonitis occurs with the entry into the peritoneal cavity of bile leakage due to various causes, including cholecystitis-induced gallbladder perforation. Pericholecystic abscess, perforation of the gallbladder wall, is covered by the surrounding tissues along with the formation of abscesses around the gallbladder. Fistula between the gallbladder and duodenum, usually caused by a large gallbladder stone eroding through the wall of the gallbladder into the duodenum. If the stone is large in size, the person can develop gallstone ileus, with the stone causing mechanical small bowel obstruction at the ileocecal valve. Jaundice occurs in up to 10% of people with cholecystitis and may be due to biliary tract inflammation and oedema, pressure from a distended gallbladder, or a stone in the common bile duct or impacted in the gallbladder neck, Moritz syndrome. Sepsis could develop if there is superimposed bacterial infection. Pancreatitis, passage of the gallstone into the bowel, causes a temporary blockage of the bilipancreatic duct, leading to a premature release of pancreatic. Symptoms include persistent epigastric pain radiating to the back, which is relieved by leaning forwards and profuse vomiting. One study found that a serum total bilirubin level of, or greater than 68.4 mol/L on hospital day 2 predicted persisting CBD stones with enough specificity to serve as a practical guideline for ERCP, while minimizing unnecessary procedures. Empyema. The obstructed GB fills with pus. The patient may become quite toxic, and there is a marked fever and leukocytosis. Gallstone ileus. Gallstone ileus is caused by occlusion of the intestinal lumen as a result of one or more gallstones. It is a rare complication of gallstones that occurs in 1–4% of all cases of bowel obstruction. The mortality is 12–27%. The mortality rate of acalculous cholecystitis ranges from 10–50%, which is much higher than the expected 4% mortality observed in people with acute cholecystitis. In people who are critically ill with acalculous cholecystitis and perforation or gangrene, mortality can be as high as 50–60%. Suspect acute cholecystitis if a person presents with sudden onset, constant, severe pain in the upper right quadrant, lasting several hours. The pain starts suddenly in the epigastrium or right upper quadrant and may radiate around to the back in the interscapular region. Contrary to its name, it often does not fluctuate but persists from 15 minutes up to 24 hours, subsiding spontaneously or with analgesics. Nausea or vomiting often accompanies the pain, which is visceral in origin and occurs as a result of distension of the gallbladder due to an obstruction or to the passage of a stone through the cystic duct. Tenderness, with or without guarding, in the right upper quadrant. If the stone moves to the CBD, jaundice may occur. If acute cholecystitis is suspected, Assess the person to identify other symptoms and signs of acute cholecystitis. Identify risk factors for acute cholecystitis and acute calculous cholecystitis. Exclude differential diagnoses, such as gallstones and peptic ulcer disease. Identify complications, such as an abscess, perforated gallbladder, sepsis, and jaundice. History. Ask about the nature of the pain. A constant pain present for several hours is consistent with acute cholecystitis. The duration of pain can be shorter if the gallstone returns into the gallbladder lumen or passes into the duodenum. The pain is severe, steady, and they radiate to the back. Referred pain from the gallbladder may be felt in the right shoulder or interscapular region. Ask about the presence of other symptoms, such as fever chills, may be present as a symptom of infection. Nausea can occur in conjunction with severe pain and can be a prominent symptom of a stone in the common bile duct. Vomiting, sometimes associated with biliary disease, but not specific for cholecystitis. It can be a prominent symptom of a stone in the common bile duct. Anorexia, associated with biliary disease, but not specific for cholecystitis. Ask about current or previous episodes of gallstones or biliary colic. Over 90% of people with acute cholecystitis have gallstones. About 50% of the people who have had one episode of biliary pain will have another within 12 months. Ask about the presence of risk factors for calculous cholecystitis, such as recent severe illness or trauma. Look for signs of sepsis, such as extreme pain, mottled skin, fever or reduced core temperature, rigors or chills, and or shortness of breath. Suspect sepsis based on acute deterioration in a person in whom there is clinical evidence or strong suspicion of infection. The person may present with nonspecific or non-localized symptoms, such as being acutely unwell with a normal temperature, or there may be severe signs with evidence of multi-organ dysfunction and shock. Examination. Examine the person's abdomen. Palpate for right upper quadrant tenderness. Right upper quadrant mass. A distended, tender gallbladder may be palpable as a distinct mass in 30–40% of people. Presence of Murphy's sign. Inspiration is inhibited by pain on palpitation when the examiner's hand is positioned along the costal margin. Be aware that Murphy's sign is unreliable in older adults and is difficult to elicit in people who are critically ill. Look for other signs of complication, such as jaundice. Occurs in up to 10% of the people with cholecystitis and may be due to biliary tract inflammation and edema, pressure from a distended gallbladder, or a stone in the common bile duct or impacted in the gallbladder neck, Moritzi syndrome. Abscess formation and or gallbladder perforation. The person may present with persistent fever, a palpable mass, severe localized and or generalized pain tenderness. A calculous cholecystitis can present with fever, jaundice, and abdominal tenderness, and is usually a diagnosis of exclusion. It often occurs in critically ill people. Investigations. Urinalysis, CSR, and ECG may help exclude other diseases. Ultrasound is the best way to demonstrate stones, being 90–95% sensitive. Sometimes stones are not mobile, in which case they are not easy to differentiate from unimportant polyps, and very small ones may be missed or fail to throw a helpful acoustic shadow. Ultrasonography can also allow measurement of the diameter of the CBD and show the liver and hepatic bile ducts, but it can only identify with certainty about half of any stones in the CBD. If the ultrasound scan findings are negative, but there is a high level of suspicion, such as in a patient with upper abdominal pain and abnormal LFTs, it is worth repeating the investigation after an interval. This may pick up stones which were previously missed. Fuller evaluation is needed if abnormal LFTs or jaundice persist in patients with acute pancreatitis and when the CBD is noticeably dilated. Endoscopic retrograde cholangiopancreatography, ERCP, may be used for the diagnosis of CBD stones and has also evolved from a diagnostic to a therapeutic procedure for the removal of CBD stones. Computerized tomography, CT, may be useful when filling the bile duct is unsuccessful in ERCP or when the procedure cannot be used for other reasons. Other techniques which may be used include magnetic resonance, cholangiopancreatography, and endoscopic ultrasonography. Differential diagnoses of acute cholecystitis include acute cholangitis, presents with jaundice, fever, chills, and abdominal pain, acute coronary syndrome, acute pancreatitis, appendicitis, gastrointestinal cancer, gastroesophageal reflux disease, hepatitis, peptic ulcer disease, right lower lobe pneumonia, symptomatic gallstones. Management. If acute cholecystitis is suspected, admit the person to hospital for confirmation of the diagnosis, including abdominal ultrasound and blood tests, such as a white blood cell count, C-reactive protein, and serum amylase. Monitoring, for example, blood pressure, pulse, and urinary output. Treatment may include intravenous fluids, antibiotics, and an analgesia. Surgical assessment for cholecystectomy. Gallbladder stones non-surgical management. Biliary colic and acute cholecystitis. These are conditions which will usually respond to an opioid such as morphine or pethidine given parenterally and/or diclofenac by suppository. These routes will overcome difficulties in absorption caused by vomiting. Pain continuing for over 24 hours or accompanied by fever usually necessitates hospital admission. It is generally considered that patients who require antibiotics should have them intravenously in hospital. There is no evidence base to support the use of oral antibiotics at home, except where the patient has been discharged from hospital after a course of intravenous antibiotics but without having had surgical removal of the stones. One study also supported current guidelines that antibiotics before elective cholecystectomy were unnecessary. Chronic cholecystitis. The same principles apply to acute attacks of pain in patients with chronic cholecystitis. The management of silent stones. Patients should be managed on a case-by-case basis. 1 to 4% of asymptomatic patients develop problems related to gallstones annually, so the odds are in favor of a watch-and-wait policy. Younger patients tend to develop complications more frequently because they have a longer time for the gallstones to cause problems, and smaller stones cause more problems than larger ones, as they are more likely to become dislodged. Gallbladder stone surgical management. Early cholecystectomy, to be carried out within 1 week of diagnosis, is recommended by the National Institute for Health and Care Excellence, NICE, for people with acute cholecystitis. Laparoscopic cholecystectomy is the preferred procedure. There is no difference in mortality, postoperative complications, or operative time compared with open cholecystectomy. However, hospital stay is shorter and recovery time is quicker. Day case surgery has been shown by studies to be as safe and as acceptable to patients as overnight stay surgery and is more cost effective. Percutaneous cholecystotomy, surgical drainage of the GB, is useful for patients who are unfit for cholecystectomy. Natural orifice transluminal endoscopic surgery, notes, has been developed. The peritoneal cavity is accessed via a natural orifice such as the mouth, rectum, or vagina. Cholecystectomy via a gastroscope without laparoscopic guidance has been reported. Risks of surgery. Postoperative complications are rare but do occur. The most significant is injury to the bile duct, which occurs at a rate of 0.2% in both open and laparoscopic surgery. Fat intolerance may develop in a small proportion of patients, and a low-fat diet is recommended. However, evidence to support the usefulness of this diet is weak. Post-cholecystectomy syndrome refers to a heterogeneous group of symptoms and findings in patients who have undergone cholecystectomy. It's a rare situation. These patients can present with abdominal pain, jaundice, or dyspeptic symptoms. Bile duct stones management. The most recent guideline suggests cholecystectomy and exploration of the CBD if the GB is present, preferably through a laparoscope. Biliary sphincterotomy and endoscopic stone extraction if the GB has been previously removed. Consider a biliary stent if stones are retrievable, may be definitive treatment if the patient is unfit for surgery. Laparoscopic duct exploration and ERCP, supplemented by endoscopic papillary balloon dilatation EPBD with prior sphincterotomy. Mechanical lithotripsy or cholangioscopy where necessary should be considered in difficult cases. Percutaneous stone extraction and open surgery should be used as a last resort. There appears to be a range of practice with respect to the use of endoscopic surgery in the management of CBD stone. Despite the guidance from the BSG, a Cochrane review found that open bile duct surgery seemed superior to ERCP in clearing CBD stones. There was no significant difference in the mortality and morbidity between laparoscopic bile duct clearance and the endoscopic options. There was no significant reduction in the number of retained stones and failure rates in the laparoscopy groups compared with the preoperative and intraoperative ERCP groups. Management of complications. Cholangitis. Medical treatment includes broad-spectrum intravenous antibiotics and correction of fluid electrolyte disturbance. Surgical decompression of the GB may be required. Endoscopic drainage has replaced emergency surgical common duct exploration and T-tube drainage in patients with severe cholangitis. Percutaneous transhepatic biliary drainage (PTBD) is another option. MPMA, intravenous antibiotics are combined with urgent decompression and removal of the GB. Decompression may be carried out via a laparoscope under radiological guidance prior to GB resection, as this makes the GB easier to handle. The conversion to open cholecystectomy is fortuitous 80%, but complications are no higher with laparoscopic removal than with open surgery. One study suggested that conversion rates are proportional to the experience of the surgeon. Gallstone ileus. Treatment is traditionally by laparotomy and milking the obstructing stone into the colon or by enterotomy and extraction. Recently, laparoscopic techniques have been used. Prevention. Ursodeoxycholic acid is useful in preventing high-risk patients, e.g., morbidly obese patients undergoing rapid weight loss following bariatric surgery, from developing gallstones. However, studies suggest that ursodeoxycholic acid has no effect on the reduction of biliary symptoms once the stones have formed. It is suggested that a healthy lifestyle, regular physical activity, and the maintenance of an ideal body weight might prevent cholesterol stones and symptomatic gallstones, but the evidence here is weak.